Assalamu alaikum, good morning everybody. Today inshallah we are going to cover the cardiac cycle and the cardiac output. The objectives of today's lecture are to describe the phases of cardiac cycle, to define the pressure and volume changes that occur during a cardiac cycle, relate the timing of heart sounds to the ECG waves and the pressure changes during systole and diastole, identify the origin of the heart sounds that clinicians can hear using the stethoscope, define cardiac output, describe the factors that regulate stroke volume, and describe or discuss the Starling law of the heart, and finally outline the factors that regulate the heart rate. As you know, the heart is composed of 4 chambers and it has 4 valves. 2 valves separates the atria from the respective ventricles, and these are called the atrioventricular valves or the AV valves, and these are the tricuspid valve on the right side and the bicuspid or mitral valve on the left side. The semilunar valves or SL valves, these are the pulmonary valve that separates the right ventricle from the pulmonary trunk, and the aortic valve that separates the left ventricle from the ascending aorta. And the respective valves are here in the figure. The cardiac cycle is defined as a cycle that includes all events associated with one heartbeat. So the cardiac cycle are all the events that occur in one heartbeat. It consists of systole and diastole of the atria and ventricles. In each cycle, atria and ventricles alternately contract and relax. During atrial systole, ventricles are relaxed, and during ventricular or ventricle systole, the atria are relaxed. Systole or contraction of the myocardium of the heart forces blood from areas of high pressure to areas of lower pressure, and we know very well that the pressure gradient is the driving force for blood flow in the cardiovascular system. What are the phases of cardiac cycle? When the heart rate is 75 beats per minute, one cardiac cycle lasts for 0.8 seconds. And this cardiac cycle can be divided into 3 main phases. These are the atrial systole that lasts for 0.1 second, where the atria are contracting but the ventricles are relaxed. Then we have the ventricular systole that lasts for 0.3 seconds, where the ventricles are contracting but the atria relaxed in the atrial diastole. Finally, or the last phase of a cardiac cycle is the relaxation period. It lasts about 0.4 seconds, where both atria and ventricles are relaxed. If we add 0.1 to 0.3 to 0.4, which are the durations of the different cycles, we get the total of 0.8 seconds, which is the duration of one cardiac cycle. The faster the heart beats, the shorter the relaxation period, whereas the durations of atrial systole and ventricular systole shorten only slightly. So with higher heart rate, the diastole will be affected more than the systole and the atrial systole and the ventricular systole. Here we can see the ECG changes that occur in one cardiac cycle. We can see the pressure changes that happen in the chambers of the heart and in the main blood vessels that arise from the heart. And in this figure, mainly the focus is on the pressure changes on the left side of the heart, including the aorta that arises from the left ventricle. Also, during the cardiac cycle, there are heart sounds that can be listened to using a stethoscope, and the contraction of the ventricles, and I'm talking here about left ventricle in this example, will lead to the ejection of blood, so the blood volume will change in the left ventricle. Okay, so as we studied in the previous lecture, we said the P wave represents the atrial depolarization, and I said that shortly after atrial depolarization, the atrial contraction will start, and this will pump one-third of it will pump the last third of ventricular filling, and then after that the QRS complex, which represents the the ventricular depolarization. Shortly after that, the ventricular contraction will start, and we can see that the pressure in the left ventricle will increase dramatically from 0 to 120, and then with the T wave, the relaxation, or after the start of T wave, the relaxation of the ventricles will start, and this lead to a drop in the left ventricular pressure. As you can see here, this red line represents the aortic pressure. The aortic pressure will rise with ventricular contraction because blood is ejected into the aorta, so the pressure will rise to 120, and then it will start to drop with the ventricular relaxation or ventricular diastole, but it won't drop to 0 like the left ventricle. It will drop to around 80 due to the closure of the aortic valve. The closure of the valves is represented or can be associated with heart sounds that we'll discuss in one of the coming slides. Just to attract your attention here, you can notice that ventricular filling with blood, the volume of blood in the left ventricle at the end of ventricular filling is about 130 millimeter, and with the strong left ventricular contraction, about 70 milliliter of blood will be ejected in the aorta, and this is responsible for the pressure change that will happen in the aorta. At the end of the ventricular systole, the blood that is left into the left ventricle is only 60 milliliter of blood, and this is called the end systolic volume. So at the end, or the blood that remains in the left or right ventricle at the end of systole is called the end systolic volume. And then after the systole, the AV valves will open, the mitral valve will open, which is present on the left side, so blood will start to flow into the left ventricle from the left atrium, so the volume inside the left ventricle will increase. So atrial depolarization is followed by atrial systole and end diastolic volume number 3, which is the volume of blood at the end of diastole just immediately before the start of the ventricular systole. Then this is followed by ventricular depolarization, the QRS interval, and this leads to the isovolumetric contraction. There is a change in the tension in the wall of the left ventricle without change in the volume inside the left ventricle. That's why it is called isovolumetric contraction without change in the volume. This isovolumetric contraction will lead or is followed by ventricular ejection, and the ejection of blood will result in emptying blood or ejecting blood into the aorta, and the blood that remains in the left ventricle is called the end systolic volume. And then the ventricular repolarization will start, and this is represented by T wave on the ECG, and leads to isovolumetric relaxation, where the ventricle, the tension in the wall of the ventricle will decrease, but there is no change in the volume of the left ventricle. And then the decrease in the pressure inside the left ventricle will open the mitral valve, so it will start filling. Ventricular filling will happen, which increases again the volume inside the left ventricle. Okay, now let's talk about the different phases of cardiac cycle in some more details. First of all, atrial systole to happen, the sinoatrial node should depolarize. So sinoatrial node depolarization will generate a P wave on the ECG. Atrial depolarization causes atrial systole because, as we said in the previous lecture, conduction of action potential from the autorhythmic cells to the contractile atrial cells will cause their depolarization, and then this is followed by contraction, which is systole. As the atria contract, they exert pressure on blood within the atria. This will force blood through the open AV valves into the respective ventricles. Atrial systole contributes about 25 milliliter of blood to 105 milliliter that is already present in each ventricle. So at the end of atrial systole, which is also the end of ventricular diastole, the total volume of blood in the ventricle is 130 ml. Only 25 ml of that blood is contributed by atrial systole. The first 105 millimeters or milliliters of blood flow from the atria to the ventricle by gravity. The end of atrial systole is also the end of ventricular diastole. At this time, each ventricle contains about 130 ml of blood, and this volume is called end diastolic volume. And it is end diastole in the ventricle, so it is the end diastolic volume inside the ventricle, and it is equal to 130 ml on average in adult human. The second phase of the cardiac cycle, which is the ventricular systole, ventricular depolarization after the action potential passes through the AV node, delay in the AV node of 0.1 second. It will pass to the AV bundle, and then it will spread through the bundle branches and Purkinje fibers, leading to ventricular depolarization that can be seen as a QRS complex or QRS interval on the ECG. The ventricular depolarization will cause ventricular systole. As ventricles contract, pressure inside the ventricles rises and pushes the atrioventricular valves shut down. So it will close the atrioventricular valves. And these atrioventricular valves are the mitral and tricuspid valve. During this period, which is about 0.05 second, all valves are closed and the ventricles are contracting isometrically, so without volume changes. There is just built-in tension in the wall of both ventricles without change in the volume of the ventricular chamber or the ventricle chamber. This phase is called isovolumetric contraction. The contraction will continue, and this will cause the pressure inside them to rise sharply when left ventricular pressure becomes more than the aortic pressure, and when the right ventricular pressure becomes more than the pulmonary trunk pressure. The aortic and pulmonary valves open respectively, and the blood is ejected out of the ventricles. This is called ventricular ejection. Each ventricle during systole ejects about 70 milliliter of blood. The volume remaining in each ventricle at the end of ventricular systole is about 6 milliliter and is called the end systolic volume, ESV. Stroke volume, or SV, is the volume of blood ejected per beat from each ventricle. And since I said that 70 ml of blood is ejected from each ventricle, so the stroke volume of the right ventricle is 70 milliliter, and the stroke volume of the left ventricle is 70 milliliter. And we can obtain the stroke volume by subtracting the end systolic volume from the end diastolic volume. 130 milliliter minus 70 milliliter, and this will lead to the stroke volume, which is 70 milliliter of blood. So stroke volume is equal to n diastolic volume minus n systolic volume, 130 minus 60. The result is about 70 milliliter per beat or per cardiac cycle. The third phase or period of the cardiac cycle is the relaxation period. Ventricular repolarization, that is represented by number 8 in the large figure that we saw previously, causes ventricular diastole. As the ventricles relax, pressure within the chambers drop. The blood in the aorta and pulmonary artery starts to flow back, and this causes the semilunar valves to close. So both the aortic and the pulmonary valves will close at the beginning of ventricular repolarization or of ventricular diastole. All valves now are closed and the ventricular volume doesn't change, and this is called isovolumetric relaxation. As the ventricles continue to relax, the pressure drops below the atrial pressure, and this will lead to the opening of the atrioventricular valves. And this will signal the beginning of ventricular filling, because the atria now contain blood that arrived through venous return, so the blood will flow from the atria to the respective ventricle via the AV valves. I mentioned in the objectives the heart sounds. So what are the heart sounds? Auscultation, or when we listen to the chest using the stethoscope, we can hear the heart sounds. Auscultation is the act of listening to sounds within the body, and one of these sounds are the heart sounds. Heart sounds or sounds of the heartbeat comes primarily from blood turbulence caused by closing of heart valves. So we have 4 valves. The AV valves usually close at the same time, and the semilunar valves close at the same time, and different from the AV valves, so we can hear mainly 2 main sounds. 4 heart sounds in each cardiac cycle are heard. Only 2 are loud enough to be heard. The first heart sound, which is lob, heard as the sound of lob, it is due to the closure of the atrioventricular valves, the mitral valve and the tricuspid valve. Then the second heart sound, which is S2, it is heard like dub. It is due to the closure of semilunar valves. The first heart sound, S1 or lob, it is louder and longer than the second heart sound. The second heart sound, S2, is shorter and is not as loud as the first heart sound. It is caused, or the first heart sound is caused by turbulence of blood due to the closure of AV valves soon after the beginning of ventricular systole. So S1 is due to the closure of the AV valves. The second heart sound is caused by turbulence of blood due to the closure of the SL valves or the semilunar valves after the beginning of ventricular diastole. S3 is due to turbulence during ventricular filling. It is not loud enough to be heard by the stethoscope. S4, if it is heard, it is due to the turbulence during atrial systole, during the contraction of the atria to push the last 25 ml of blood into the ventricles. S1 and S2 are best heard on the surface of the chest in specific locations as shown in this figure. You can see here that the best place to hear the tricuspid valve is here, just in the lower part of the middle chest. The bicuspid valve or mitral valve is heard best on the left side of the sternum, while the other 2 valves are best heard in the second intercostal space on the right and the left side of the sternum. Right for the aortic and left for the pulmonary valve. Heart murmurs are abnormal sounds. These are not S1, not S2, and not S3 or S4. So clicking, rushing, or gurgling noise heard before, between, or after the normal heart sounds, or that might or may mask the normal heart sounds. So it is a noise that can occur during, after, or before, or even mask the normal heart sounds. Most often, a murmur indicates a problem or disorder in the valve, in one of the valves. Now we go to the second part of the lecture, which is the cardiac output and how to regulate the cardiac output. But before starting that, let's remember important cardiovascular system definitions, and these are: heart rate is the number of heartbeats per minute, and the average is between 60 and 100 beats per minute. And we said that at rest the heart is under the parasympathetic tone, so the average is usually not 100 but 70 beats per minute. The end diastolic volume is the amount of blood in each ventricle at the end of ventricular diastole. It is just before the start of the ventricular systole. It is between 110 to 120 or 130, and it varies from person to person. The end systolic volume is the amount of blood remaining in each ventricle at the end of ventricular systole or just before the start of ventricular diastole. It is between 40, 50 or 60, as I explained in one of the previous slides. The difference between these two volumes is the stroke volume. Stroke volume is the amount of blood pumped or ejected out of each ventricle during a single beat. So it is about 70 milliliter of blood. It can be expressed as follows: stroke volume is equal to end diastolic volume minus end systolic volume, 110 minus 40, and is equal to 70 milliliter. Ejection fraction is percentage of the end diastolic volume represented by the stroke volume. It is about 55 to 65%, and it is calculated as follows: stroke volume divided by the end diastolic volume multiplied by 100. So if the stroke volume is 70, the end diastolic volume is 110, then the ejection fraction is 63. So it is what is the percentage of the end diastolic volume that will be ejected from each ventricle. This is the meaning of the ejection fraction. Cardiac output is the volume of blood ejected from the left or the right ventricle into the aorta each minute. It is not from left and, it is from left or right. So we don't combine the volume of blood ejected from both ventricles. Cardiac output is the volume of blood ejected per ventricle in 1 minute. Please be careful. So if I ask what is the cardiac output of the right ventricle, it is the volume of blood ejected from the right ventricle into the pulmonary trunk in 1 minute. Cardiac output of the left ventricle, it is the volume of blood ejected from the left ventricle into the aorta in 1 minute. So it is per ventricle, not from both ventricles. We can calculate cardiac output by multiplying stroke volume, which is the volume of blood ejected per beat or per cardiac cycle, by the number of cardiac cycles in 1 minute, which is the heart rate. So cardiac output, liters per minute or milliliters per minute, is equal to the volume ejected per beat from each ventricle, milliliter per beat, multiplied by the heart rate, which is the number of beats per minute. In typical resting male, which means at rest, the cardiac output is around 5 liters per minute, which is the product of 70 milliliter per beat, which is the stroke volume, multiplied by the heart rate, which is 75 beats per minute. The entire blood volume flows through the pulmonary and systemic circulations each minute. So in 1 minute, the pulmonary circulation will receive 5 liters, and also in 1 minute, the systemic circulation will receive the entire cardiac output of the left ventricle, which is about 5 liters. Cardiac reserve is the difference between the maximum cardiac output and cardiac output at rest, because during physical activity the cardiac output will increase several times. So if we subtract the cardiac output at rest from the maximum cardiac output, then we can get the cardiac reserve. The average cardiac reserve is 4 to 5 times resting value. So it means that the maximum cardiac reserve could be up to 20 or 25 liters per minute. Athletes or well-trained athletes or individuals may reach 7 to 8 times. So their cardiac output or their maximum cardiac output could be up to 35 or 40 liters per minute. Heart failure patients have little or no cardiac reserve. So their cardiac reserve is very low due to the failing heart muscle or the failing pump of the cardiovascular system. As I said, the cardiac output is the product of multiplying the stroke volume by heart rate. So if we want to change or control the cardiac output, we have either to control the stroke volume or the heart rate, or both together. For example, if we want to increase the cardiac output, we have to increase the heart rate or increase the stroke volume or increase both of them. So now let's discuss the regulation of the stroke volume, and then discuss the factors that regulate or affect the heart rate. A healthy heart will pump out the blood that entered its chamber during a previous diastole. So it will pump whatever it receives. At rest, the stroke volume is about 50 to 60% of the end diastolic volume, and this is the ejection fraction. 3 factors regulate or affect the stroke volume and ensure that the left and right ventricles pump equal volumes of blood. These factors are the preload. It is the degree of stretch placed on the heart before it starts its contraction. So how much the ventricles are stretched or expanded with the end diastolic volume just before the start of the contraction or ventricular systole. Contractility is the forcefulness of muscle fibers. So it depends on how strong the muscle fibers will contract during systole, and usually this is the function of calcium. The more the calcium is provided to the cardiomyocytes, the stronger the ventricular systole will be. The third factor that affects the stroke volume is the afterload. The afterload is the resistance to the ejection of blood from either ventricles. So it is the pressure that must be exceeded before ejection of blood can occur. So this is the pressure in the aorta and the pressure in the pulmonary trunk. So the afterload of the left ventricle is the pressure in the aorta. The afterload to the right ventricle is the pressure in the pulmonary trunk at the beginning of the ventricular systole. Let's talk about each factor separately. The preload, as I said, is the degree of stretch on the heart before it contracts, before the start of the sliding of the thin and thick filaments past each other in the sarcomeres. The greater the preload, or greater preload, increases the force of contraction, and this is known as the Frank-Starling law of the heart. Frank-Starling law of the heart states that the more the heart fills with blood during diastole, and here we are talking about the ventricles mainly, the greater the force of contraction will occur during systole. Of course, like any other physiological system, it is within limits. If we exceed the limits, then the force of contraction will decline dramatically, and this is what happens in heart failure, as you will see in phase 2 inshallah. The preload, since it is the degree of stretch of the ventricles by blood, and this degree of stretch is determined by the volume of blood present in the ventricles at the end of diastole. So preload is proportional to the end diastolic volume. Two factors determine the end diastolic volume. Number one, the duration of ventricular diastole. So if we give longer time for the ventricles to relax, then the ventricles will fill more with more blood. This will stretch the ventricular wall to a larger extent, and finally this will lead to stronger contraction or stronger force of contraction. The second important factor that determines the end diastolic volume, or the volume of blood that will be in the ventricles at the end of ventricular diastole, is the volume of venous return. Venous return is the volume of blood returning to the right ventricle per minute. So we have the right ventricular venous return, and we have the venous return to the left side. So it is just the amount of blood returning to any ventricle or to each ventricle in 1 minute, and theoretically it should be exactly equal to the cardiac output, because we said the heart will pump whatever it receives. If the heart receives 5 liters of blood per minute, it will pump 5 liters of blood per minute. This is what the normal heart will do. The second factor is contractility. It is the strength of myocardial contractility at any given preload. So if I have a ventricle distended, let's say with 130 milliliter of blood, which is the end diastolic volume, and I provide, let's say, 100 ions of calcium, it will give me a certain degree of contraction. I have the same example, a ventricle with 130 milliliter, but in the second example I have 200 ions of calcium inside the cytoplasm of the cardiomyocytes. In the second example, the contraction or the force of the contraction will be double the first example, because, as I said, contractility or the strength of contraction at any given preload is the function of calcium. There are drugs or agents that increase the contractility because they will increase the concentration of calcium inside the cytosol of the cardiomyocytes, and we call these drugs the positive inotropic drugs or agents. These are substances that increase contractility. Often they promote calcium inflow during cardiac action potential, and this will increase the force of contraction and the stroke volume. The SNS stimulation, the sympathetic nervous system stimulation, epinephrine, norepinephrine from the adrenal medulla or as injections, and digitalis, which is a drug that is used in the cardiac conditions. All of them are positive inotropic agents. Negative inotropic agents are substances that decrease contractility, and examples of that: inhibition of the sympathetic nervous system, anoxia, acidosis, some anesthetics, and increased potassium in the interstitial fluid. The afterload, it is the pressure that must be overcome before a semilunar valve can open, and this is called, as I said, the afterload. Afterload depends on the elasticity of large arteries and peripheral resistance of the arterioles. Pressure in the right ventricle to exceed the pressure in the pulmonary trunk, about 20 millimeter mercury, and pressure in the left ventricle has to exceed the pressure in the aorta of about 80 millimeter mercury. At this point, only the semilunar valves will open and blood will be ejected into these large blood vessels. An increase in the afterload causes stroke volume to decrease. So less blood will be ejected, so I have less stroke volume, and this will increase the end systolic volume in each ventricle. So increase in the afterload causes stroke volume to decrease, so that more blood remains in the ventricles at the end of systole. Hypertension, high blood pressure, and atherosclerosis, less of elasticity in the large arteries, and we are talking mainly about the aorta in this case, will increase the afterload. So this, or one of these or both factors, will decrease the stroke volume and eventually will decrease the cardiac output. Now let's discuss the other factor that affects the cardiac output in addition to stroke volume, which is the heart rate. So what are the factors that regulate or affect the heart rate? Cardiac output depends on heart rate and stroke volume. We already discussed the factors that affect the stroke volume. These are preload, contractility, and afterload. Now let's discuss the heart rate. Adjustments in the heart rate are important in short-term control of cardiac output and blood pressure. The SA node initiates heartbeats, and if let alone will set it at 100 beats per minute, because their firing rate, as we saw in the previous lecture, is 100 action potentials per minute, and this will be translated into 100 beats per minute. There is a term called tachycardia, which is an elevated resting heart rate above 100 beats per minute at rest. The other term is bradycardia, or slow heart. Resting heart rate is less than 50 to 60 beats per minute. Normal function of the body requires different heart rates. So the heart rate that is sufficient at rest is not sufficient during physical activity. Therefore, we have to increase the heart rate in order to increase the overall cardiac output, and you have better flow or sufficient flow to the exercising muscles. Most important factors that regulate the heart rate are the autonomic nervous system, sympathetic and parasympathetic divisions, as well as hormones, mainly epinephrine and norepinephrine. The autonomic regulation of the heart rate, fibers that regulate the heart, or autonomic fibers that innervate the heart, they originate in the cardiovascular center of the medulla oblongata, increases or decreases frequency of nerve impulses in both sympathetic and parasympathetic branches of the ANS, or the autonomic nervous system. Sympathetic nervous system stimulation will increase the release of norepinephrine from the sympathetic endings, and that has two separate effects on the heart. The first effect is to increase the SA node and AV node speed. So it speeds up the rate of spontaneous depolarization and therefore increases the heart rate and the conduction through the AV node. In the contractile fibers, norepinephrine enhances calcium entry and therefore increases the contractility. So it is an inotropic agent. The parasympathetic fibers release acetylcholine, which decreases the heart rate by slowing the rate of spontaneous depolarization. Here we can see the summary of the effect of both the sympathetic and parasympathetic divisions of the autonomic nervous system on the heart. The cardiovascular center in the medulla oblongata receives input from higher brain centers like the cerebral cortex, limbic system, and the hypothalamus, and also from sensory receptors, proprioceptors that monitor movement. These are mechanoreceptors in joints and muscles, chemoreceptors that monitor blood chemistry, either peripheral or central, and the baroreceptors that monitor the blood pressure. We'll study baroreceptors in the lecture of regulation of blood pressure. Input to the cardiovascular center, processing there, then we get the order through the cardiac accelerator nerves. These are the sympathetic fibers that will increase the rate of spontaneous depolarization, this SA node, and this will increase the heart rate and also will increase the conduction through the AV node. It will shorten the delay that happens in the AV node. The cardiac accelerator nerves also increase the contractility of the atria and ventricles, and this will increase the stroke volume. So the sympathetic, by increasing heart rate and increasing the stroke volume, will increase the cardiac output, which is the product of heart rate and stroke volume. Also, the motor fibers through the vagus nerve can affect the heart in a negative way, so decrease the vagus nerve, and especially in it is the 10th cranial nerve where most of the parasympathetic fibers run. It will release, or the terminals will release, acetylcholine, and this will decrease the rate of spontaneous depolarization, the SA node and AV node, and this will decrease the heart rate and will decrease the cardiac output. The chemical regulation of the heart rate is via hormones. Epinephrine and norepinephrine from the adrenal medulla will increase the heart rate and contractility. Other hormones like thyroid hormones will increase the heart rate and contractility. We have, in addition to the hormones, some cations. Ionic imbalances can compromise the pumping effectiveness of the heart, and you'll study that in more details in the cardiovascular module and the integrated modules in phase 2, inshallah. Also, the relative concentrations of potassium, calcium, and sodium are important for the heart rate. Here in this slide, we can see a summary of the different factors that affect the cardiac output, which these are stroke volume and heart rate. So if we increase the stroke volume or increase the heart rate, or we increase both of them, this will increase the cardiac output. The stroke volume is affected by preload, which is the degree of stretch of the cardiac chamber before the start of ventricular systole. The contractility is the function of calcium. So the more the calcium that is available during contraction, we have a stronger contraction. The afterload is the pressure against it, the ventricles eject blood. So if we want to increase the stroke volume, we have to increase the preload and or increase the contractility and or decrease the afterload. So if we decrease the afterload, or the resistance or pressure against which the ventricles pumps blood, then the stroke volume will increase. The factors that affect the heart rate is the nervous system through both sympathetic and parasympathetic divisions. Sympathetic will increase the heart rate and contractility. Parasympathetic will decrease the heart rate. The parasympathetic has no effect on contractility because it doesn't supply the ventricular, or it doesn't innervate the ventricular muscles. As I said, chemicals in the form of hormones or cations can also affect the heart rate, and we have other factors that I will discuss in the coming slide: the age, the gender, the physical fitness, and the body temperature. Let's talk about them briefly in the next slide. The other factors that affect the heart rate: age. The heart rate usually decreases with aging, except for the arrhythmia that might develop in old age. The gender: adult females have higher heart rate compared to male of the same age. Exercise: trained athletes have lower heart rate or lower resting heart rate compared to non-trained people, and it is usually less than 60 beats per minute. And then the body temperature also can affect the heart rate. High body temperature, either due to fever or during exercise, can increase the heart rate. And low body temperature, as in cases of hypothermia, this will decrease the heart rate. This is the last lecture of this slide. Thank you very much for your listening. Please send me your questions by email, and I will be very glad to answer them. Very much, and meet you in the next lecture, inshallah.